Okay. So our objectives for today, some acronyms: BB, beta blocker, calcium channel blocker. EPS is electrophysiology study. ICP, intracranial pressure. Pacemaker. RFA is the ablation. We can get rid of nerves, the impulses that cause these abnormal rhythms. Sinus node dysfunction, 6-9 syndrome, and then your types of echoes. Some definitions: arrhythmia or a dysrhythmia, just abnormal heart rhythms. Too slow, too fast, is it irregular, too early? What's going on with these EKGs? So we mentioned in pathophys when we talked about these arrhythmias, is it supraventricular, meaning does it originate above the ventricle? So all SVTs is an umbrella term. It's just any arrhythmia that originates in the atria. So atrial origin, AFib, a flutter, a tach. We have ectopic focuses, intraatrial or sinoatrial reentry. So we talked about we have reentry with AVNRT, and what's the other big reentry? WPW. You can also rarely have it like a cycle within the atria as well. And then atrial extrasystoles, just premature atrial beats. Then you go into your AV junction. Where can they have problems? And that's going to be your AV nodal reentry tachycardia, junctional rhythms, any AV junctional escape beats, and then anything in the ventricle side. What originates from the ventricles? What is the other clue, especially looking at ventricular, the QRS complex? Wide. If it's narrow, it follows the normal pathway, electrical conduction system, so it's a normal conduction, a normal QRS. When the beat originates in the ventricles, it's a widened QRS, so it's coming from the ventricles. So what are some causes for any type of heart rhythm disturbance? Coronary artery disease. If you have blocked arteries, you have ischemia in the tissue, it's going to get haywire and go nuts and start sending off signals. Electrolyte, pH imbalances, sodium and potassium can cause arrhythmia changes. Any heart muscle changes, you've had a heart attack and now you have reduced systolic function. Heart attack, same thing. Healing process after a heart surgery. If anyone here has seen or witnessed someone after a bypass surgery, open heart bypass surgery, they all get pacemaker wires going into the heart to make sure the heart beats appropriately. And then once the heart is functioning on its own, you just pull the wires out and the wires come right out. And then you're sealed up and you're fine. You can have some irregular heart rhythms that also occur in healthy, normal hearts. If you drink a lot of caffeine, you may feel your heart fluttering or beating hard, the PVC once in a while, like a really hard beat. That is just a stimulation from the coffee. Heart disease, neurogenic, and drug influences, and there's obviously other causes for these arrhythmias to occur. Common labs that you would get, anyone coming in with an abnormal heart rhythm, check your CBC, make sure they're not anemic. Anemia can cause arrhythmias to occur. Also can cause chest pain as well, severe anemia. CMP, magnesium level, digoxin level, if they're taking digoxin. If they're not taking digoxin, which is an antiarrhythmic, don't check a digoxin level because it's not going to go up anymore. But if they're on digoxin, then you would check it. Thyroid panel. People that have thyroid abnormalities can also have some heart rhythm disturbances. And then drug tox. Anyone with a new onset abnormal heart rhythm, check a drug tox and make sure that's going on. EPS, the electrophysiologic studies. What these do is they actually they put catheters inside the heart. So when you do an EKG, you're putting surface leads on different areas to get the electrical activity of the heart. In an EP study, we put catheters or electrodes come through the femoral vein, they come up, and they can wind up right in the right atrium. And we put these electrodes in the right atrium and we measure the electrical activity. And we'll see where these conductions are coming from. It's a diagnostic and a therapeutic tool. So therapeutic is if you have a Let's say you have a WPW, a really easy one. If you have WPW, we don't want that accessory pathway to be active. So the EP study, the cardiologist, which is a tertiary level of cardiology, they'll go in there, they'll see where this is coming from, they'll initiate the AV-NRT or the WPW, and then they just find out where that little nerve is, and then they ablate it with that radio frequency so that that nerve is not active and it won't conduct any more electricity, therefore cutting that pathway. Ablation is what they used. There's radio frequency. There's also a temperature ablation using cold, and it freezes the skin, or not the skin, the tissue, so it can't conduct any more electricity. So those are the different ways they can ablate. This is actually a curative treatment. You're cutting out the nerve signal so it's not going to do anything anymore, and you can cure them of these heart rhythm disturbances. It's one of the only real cures in cardiology. Pacemakers. What do pacemakers do? All pacemakers do is they're a bottom. And all you're saying is with a pacemaker, you say that the heart should never go less than 60. So you set the device and you say the heart rate should never go below 60. So this way, if the person's heart through like sick sinus syndrome where there's no beat generated, nothing's going on, these pacemaker wires wait, and if they don't see a beat happening within that time frame, they will discharge a signal to tell the heart to beat. That's all pacemakers do. They're to prevent bradycardia. That's it. They don't do anything else with fast heart rhythms. They're just there to protect you from going too low. That's all pacemakers do. They can be single or dual chamber, meaning you have one lead in the atria, one lead in the ventricle. And they sense both chambers, and then they'll conduct whatever algorithm they have that's programmed to make sure your heart rate never goes below a certain number. That's what's called on demand, meaning it's only going to work when you need the pacemaker to work. Obviously, if someone has complete heart block, there's no communication between top and bottom, so in that case, you would probably give them a ventricular pacemaker and an atrial one so that you'll sense the atrial, and then you can tell the ventricles to beat for you in time. So the ventricle rate isn't 30 or 20. Remember, in complete heart block, what's the intrinsic rate of the ventricles? 20 to 40. That means if you have complete heart block, your ventricular rate is dropping down to 20 to 40. If you have a pacemaker, that ventricular rate will never drop below whatever number that you set. It's like an air conditioning. You set it at 76, so it'll, well, whatever it is, higher, that's higher. The heat. You know the heat, it's the heat. AC is the defibrillator. Okay, so here is what it looks like under X-ray. This is how small pacemakers can get now. This is an MRI safe one, that's why it has MRI on it. Some of these are safe to go in MRIs. The big problem is not it's going to get yanked out of your skin. That could be a problem too. The leads can be pulled out. But the other thing is the magnetic will scramble the programming in the device. So if you have a patient who has got a pacemaker or a defibrillator inside and you need them to get testing done, you'll put a consult out to the company that makes that pacemaker. There's only like 3 or 4 of them. The rep will come out, they put a little wand over the device, and through Bluetooth, they can get all the information off the device. How much has been used, all the programming, they can save it. You go for your scan, then you come back out, and they'll reprogram it, make sure it's back to normal again. So that's what pacemakers do. This is actually a defibrillator. This is way too big to be a pacemaker. A defibrillator, remember, it's got to carry battery with it. Just like a defibrillator, the external ones, we have a battery pack, have to make sure it's charged. Same thing here with these defibrillators. So this is actually pretty big, and there's another clue on this X-ray that tells me I know it's a defibrillator, not a pacemaker. The shock coils. Do you see how thick this is right here, and how that thick is down there? Those are the shock coils on the lead. So you know, you do a defibrillator, you do like a clear, and you put the pads here and here. Why do you put the pad here and here? What lead is this? What lead? What lead goes from the upper right shoulder down across the main vector of the heart? Lead 2, right? Yes, lead 2. You put paddles here to make sure you get the right conduction between those 2 points is right in the middle of the heart. If you did it like this, it would be different. So that's why the coils are set up in that way. You have one coil up top, one coil on the bottom, and they'll synchronize and they'll shock the heart back to normal rhythm. So that's what a defibrillator looks like. Okay. AICD, automated implantable cardioverter defibrillator. So it does 2 things. It cardioverts and it defibrillates. What's the difference? What does cardiovert mean? What are we talking about? Put you out of a rhythm. Atrial fibrillation, we cardivert atrial fibrillation to get you back into a normal rhythm. Usually it's got to be at a lower joule. So the energy output in a cardioversion is very low, but a defibrillator is going to get you out of ventricular fibrillation. And that requires a lot of energy. So if any of you got trained in the past on defibrillators, you know, like cardioversion is about 100 joules, but defibrillation is like 200 to 210 joules because of the amount of energy needed. So defibrillators, they will function as a pacemaker, but they have the added function to defibrillate if you go into a bad heart rhythm, such as ventricular fibrillation. Okay. Now, as a tip for EKG, if you are not repeatedly looking at EKGs, you will not do well. You have to look at EKGs. You can't look at this one and like, okay, that's sinus bradycardia, move on. Look at many different types of sinus bradycardia. Get used to looking at EKG 12 leads and rhythm strips. There are tons of free websites on the web. Like SkillStat, I think, is one of them, 5-minute EKG. There are a bunch of them, and all it is just repeated EKGs one after the other. So rhythm strips and whatnot. Get used to seeing them, look for rhythm patterns, get used to them and keep looking at them. So sinus brady, all sinus brady means, sinus means what? Normal pathway of the heart. Sinus node, AV node, Purkinje fibers. If you say sinus anything, brady, tachy, sinus rhythm, it means P wave, QRS complex, T wave. Heart rate, the only thing that's going to be abnormal in sinus brady is the heart rate. Everything else is going to be normal. Rhythm, normal. P waves, normal. PR interval, normal. QRS, normal. T wave, normal. ST segments, normal. The only thing abnormal is the rate. Sinus brady, due to malfunction of the SA node. Symptoms, usually asymptomatic, but if they start getting really low heart rates, syncope can also happen as well. They can pass out, weakness, fatigue. Causes for sinus brady, an MI can do sinus brady. Hypothermia, so severe cold, and thyroid abnormalities can also cause issues with sinus bradycardia. Increased intracranial pressure will also cause sinus brady. And drugs, most common is your beta blockers. They're going to reduce the rate, therefore giving you a sinus brady rhythm. Non-DHP calcium channel blockers, DIG, and some other antiarrhythmics. So these are things that can cause bradycardia to happen. Brady treatment, don't worry about treating them if they're asymptomatic, but when they start getting symptoms, then you got to worry about things. Treat any underlying cause of their bradycardia. If they're severe and symptomatic, you can give atropine first or atropine. May not have an effect. And if you can't treat them medically, they're very symptomatic. They're very tired, fatigued because their heart rate is so low. And the medicine that you want to give them is, one of the side effects is going to be lower heart rates. Because of that, just give them a pacemaker. The pacemaker will prevent and protect the heart rate from going low. You can give them as much beta blockers as you want. That heart rate will never go below whatever number you set it on the pacemaker. So if they're symptomatic sinus bradycardia, they get a pacemaker. There's no real medication you can give. The atropine is mainly in a emergent environment situation. Sick sinus syndrome, also known as sinus node dysfunction. This is going to be either sinus arrest versus sinus block. Basically, anytime you have a pause more than 3 seconds, it's considered a sinus block. It means you have heart rate, and then you have this big, long pause here at the bottom. There's no P wave going on. That means that there's no signal coming from the SA node because there's no P waves there. This is just a sinus pause. Obviously, there's no heartbeat going on. There's no systole. There's no movement of blood really out of the heart in this case. This is where you can get lightheaded and dizzy and pass out. Causes for sinus node dysfunction, meds can do it. Infiltrative diseases, again, we talked about them before. Amyloidosis, sarcoid, lupus. These are all infiltrative diseases that deposit their complexes in the tissue. And if it gets deposited into the SA node, it'll cause dysfunction there. Muscular dystrophy is another one. So looking at that, obviously this is sinus brady with a pause. Sick sinus node treatment. Again, whatever the underlying cause, whatever reason they have sick sinus syndrome in the first place, if it's there, treat it. This last little bit here. If the EF is normal, and how do you check the EF? Echo, just get an echo. The echo will tell you the EF. The cardiologist will read it, they'll give you the report, and they'll say EF is 55 to 60%, and you know you're normal. If your EF is normal, you get a pacemaker. If the EF is less than 35%, you get a defibrillator. Why do you get a defibrillator when the EF is less than 35%? What happens to the heart when the EF gets that low? Doesn't matter, stop. When we're talking about defibrillators, what do defibrillators do? Fast heart rates or slow? Defibrillators are for fast. Defibrillators take care of fast heart rhythms, ventricular fibrillation, get you out of that rhythm. Atrial fibrillation, fast heart rates, get you out of that rhythm. So AICDs are for fast heart rates to get you out of it. If your EF is less than 35%, the risk of sudden cardiac death goes way up. And what are they going to die of? Ventricular fibrillation or tachycardia. They go into a bad heart rhythm they can't get out of, and they pass away and die. So if their EF is low, you give them a defibrillator because it's going to protect them from sudden cardiac death. If the EF is normal, the risk of sudden cardiac death is not as great. They'll be okay with a pacemaker to control the low heart rates. You guys understand the difference between a defibrillator and a pacemaker? Pacemaker is just for slow heart rates. That's it. The defibrillator will do the slow heart rates as well, but it also protects you against the fast ones. VFib, VTAC. So the EF is important because as it goes down, you've had massive heart attack and half of your muscle tissue is gone now. The heart's not going to squeeze as well. You got dead tissue there, which doesn't conduct electricity as well, so it's causing some weird circuits occurring, and you get VFib forming, and then that's it. So that's why it's important to know the EF. Sinus tach, again, everything is going to be normal. The only difference with sinus tach is the rate is fast. That is it. That is the only thing. So if you have all your arrhythmias in a row, like in a column, and then you go through your Rahi across everything, only one arrhythmia will have the right criteria. So sinus brady, the rate is going to be low, everything is normal. Sinus brady. Sinus tach, the rate is fast, everything is normal. Sinus tach. We get to the AV node blocks. We start seeing those changes. We see what's going on there. So sinus tach, rule out any causes for sinus tach. What are some causes? Physiological response, exercise. You're all going to be in a sinus tach during exercise, but that's a normal response. That's what you're supposed to do. Fever also raises the heart rate. Okay, I've gotten call. One of my jobs before I became with here full time, I was working night call, covering a bunch of different hospitals in Orlando, and I would get calls from the nurses saying, "Now the patient's heart rate's 110, 120. Do you want to do anything about it?" And I'll say, "Well, do they have a fever?" And they say yes. And I'm like, "Well, just treat the fever. Don't worry about the heart rate. Once the fever comes down, the heart rate will come down too." What would happen if I gave that person with a fever that 110, 120 heart rate? What if I gave them a beta blocker? And then the fever breaks. Now what happens to their heart rate? It goes real too low. So that's a normal response to sinus tach. Don't treat the tachy, treat the fever, it goes away. Sepsis, medications, stimulants will do it, caffeine, cocaine, amphetamines. Dehydration, hypovolemia, they go together. Anemia makes sense. We have less trucks going through the area because we have less red blood cells. Let's get them moving faster. How do we do that? Increase the heart rate. Hyperthyroidism, pheochromocytoma. What's that again? It's a tumor of the adrenal medulla. So it's always busting out, blowing out what? Catecholamines. What's that going to do to your heart rate? Raise it up. Hypotension shock is over there. Heart failure, PE. Remember, one of the main early symptoms of a PE is tachycardia. Ischemia, pulmonary disease, hypoxia, shock, and inappropriate sinus tach. So what do? First of all, make sure it's physiologic or is it pathologic tachycardia. If it's physiologic tachycardia, leave it alone. If it's pathologic tachycardia, what's the underlying cause? If they're coming in because they have a PE, that's what's giving the tachycardia, treat the PE, and the heart rate will come down. So that's one of the things we talk about here. There's really no medication for it, just treat the underlying cause. Here's our WPW, again, that accessory pathway. They're going to have a short PR interval due to the accessory conduction. So the PR interval is shortened because you have that sluggish QRS causing that delta wave to form. Wide QRS, delta wave, some secondary STT wave changes. And you can see in this picture here, the red arrows, which I thought I changed it. I guess it didn't change the colors. Okay. Oh, it's a different one. So here is the delta wave. It's like triangles. Can't see it very well, but you know what I'm talking about. So that is the delta wave. Pre-excitation from the accessory pathway causing these delta waves to form. And STT wave changes, that's going opposite than what it should be, right? Are those opposite T waves? T waves are supposed to be the same direction as the QRS. We're flipped. That's STT wave changes. Okay. On your exam, when you diagnose people off the EKG, you can say, in this case, sinus rhythm with WPW, or sinus rhythm with an accessory pathway. It's still sinus rhythm, right? P wave, QRS for every single one, follows the pathway conduction. It's still sinus rhythm with WPW. So don't be confused on your exam if you see two answers. You can have sinus Brady with a first degree AV block. That's totally common to see, stuff like that. So treatment of WPW, unstable patients are treated with synchronized cardioversion. They cardiovert these things because usually it's from atrial fibrillation causing ventricular fibrillation. Because of the accessory pathway, all that conduction from the atria can go down that accessory pathway and cause that recirculation to occur. If they have atrial fibrillation and WPW, give amiodarone or procainamide. So we're trying to get some drugs now. Amiodarone is good for fast heart rhythms, atrial fibrillation, ventricular fibrillation, helps get out of those, and procainamide as well. Don't use AV nodal blocking agents alone. If we block the AV node, they're going to use the accessory pathway because it's available. We don't want that accessory pathway used, so be careful with AV nodal blocking agents. Examples, beta blockers, calcium channel blockers, digoxin is here, and adenosine. So don't use it alone with WPW. You'll make that accessory pathway more accessible, easier to go into those reentry rhythms. Long-term treatment, they need ablation. You have to ablate that accessory pathway. Get rid of it, and all the conduction will only go through the AV node now. Okay, so again, it's a curative treatment. We're curing the WPW. Okay, success rate 90% or about, about 90% success rate with WPW. So it's a very good curative disease. Atrial fibrillation. When you talk about atrial fibrillation, you have to decide, is this a valvular problem or is it non-valvular atrial fibrillation? Valvular atrial fibrillation is due to mitral stenosis. What happens to the left atrium in mitral stenosis? It dilates. Why? Blood can't get through the mitral valve because of the stenosis, so it backs up in the atrium, and the atrium gets bigger and thicker from having to squeeze so much. The atria don't like to be enlarged or stimulated. So when you have this left atrial enlargement, it makes them more prone to go into atrial fibrillation. So that is due to a valvular problem. The valve, the mitral stenosis, caused the atrial fibrillation. Those patients anticoagulate with warfarin. Non-valvular AFib. They have no mechanical valve. Their mitral valve is fine. There's no stenosis there, but they have atrial fibrillation. Those patients anticoagulate with warfarin or the NOACs, which is the new oral anticoagulants, Xarelto, Pradaxa. You see those commercials all the time. And if you listen to the commercial, it says for anticoagulation of non-valvular atrial fibrillation. If you listen to the commercial, it says non-valvular atrial fibrillation because it's only good for people without valve problems. So when you're studying atrial fib, is it valvular cause, mitral stenosis, mechanical valve, or is it non-valvular? Valvular only gets warfarin. The non-valvular can get the NOACs or warfarin depending on the patient. Heart rate for atrial fibrillation, variable from 150 to 250. The ventricular rate can be fast or slow. The way that you would report, if you saw an EKG like this, you would say atrial fibrillation with fast ventricular response. Why is it fast ventricular response? What's the heart rate? We don't know, but what would it have to be? Anything over fast is what? 100. So the ventricular rate with atrial fibrillation is over 100. You would say AFib or AF with fast ventricular rate. Conversely, long-term people with atrial fibrillation over time will become bradycardic. The AV node just gets bombarded way too much and eventually it fatigues and shuts down. So eventually, atrial fib can turn into a slow ventricular response if it's less than 60. If the heart rate is normal, then you would just say this is AFib with a controlled ventricular response. It's very important to know how the ventricles are doing during atrial fibrillation. They're already going to have a hard time filling because the atria are just quivering. They're not doing anything. They're not squeezing that blood in. The atrial kick is gone. So the filling is going to be a problem. If the heart rate is going too fast, what's going to happen to the filling? It's even worse with high heart rates. You have less time to fill. And now you add in atrial fibrillation on top of that, they're going to have slow heart rates, fast heart rates. You got to know what's going on. They can be symptomatic in both. Obviously, if they're bradycardic, you're going to get a pacemaker because you have to control the rate, and eventually it'll slow down. So the rate, irregularly irregular. There's no rhyme or reason when that QRS complex is going to happen. So that's what irregularly irregular means. P wave, there's none because the atria are just fibrillating. They're not really contracting. There's no really conduction. QRS ratio, P to QRS ratio is none. PR interval is hard to see. QRS is normal because why? It's supraventricular tachycardia. There's nothing to do with the ventricles. It's following the normal pathway. QRS will be normal. So irregular rhythm. There's different types of atrial fibrillation. If they just had one episode of AFib, and then it went away and they never had it again, they're just low in AFib, you kind of just watch those people. Usually people in younger than 60. Acute AFib, new onset of AFib that lasts less than 48 hours. You could have paroxysmal atrial fibrillation, recurrent AF that typically lasts less than 48 hours and will convert spontaneously. So you go into this paroxysmal, but you come out of it. Persistent AFib, duration is greater than 7 days and would last indefinitely, but you can still give them shock therapy, cardioversion, medicine to convert them, and they go back to normal. Okay, that's persistent AFib. They'll go into it, you knock them out of it, but they'll come back later. The last one is permanent AF, and duration greater than 7 days, and they're unable to maintain sinus rhythm. They're in AFib all the time. The problem with AFib is that sometimes they don't feel it. Some patients with like acute AF or a paroxysmal, they'll know when they go into it, they'll feel it. So those patients, we give them what's called a pill in a pocket, and we'll go through the pills in a second. But basically, they just have a pill on board at home when they need it. When they go into AFib, they start taking it, and it helps to get them out of the rhythm. So those are the different types of phases of atrial fibrillation. Diagnostic workup, EKG, you'll see what's going on the 12 lead. No P waves, irregular. You could have a rapid ventricular response if it's over 100. Get an echo. See what the heart looks like. Is there any enlargement of the left side of the heart? LVH, left atrial enlargement. What's the EF? Very important to know what the EF is always. Labs, check your thyroid, because any new onset AFib, especially in an older adult, may be hyperthyroidism. So check the thyroid. And CMP to see how electrolytes are, and so forth. Additional testing you can do, exercise treadmills test. That'll look at some preliminary ischemia changes that are there with exercise. Holter monitor is 24 hours. So you put them on there for 24 hours, but if they don't have any episodes in that 24 hours, you won't see anything. So if the Holter monitor doesn't show anything, and let's say they had one episode of AF in the hospital, and now they're seeing you as an outpatient for follow-up. You want to see, are they going in and out of AFib? Holter monitor, only 24 hours. If nothing happens, then the data is basically worthless. So then you would do what's called an event monitor. An event monitor you wear for like a month, maybe more. It's got a little like a phone device hooked up to it. If you feel symptomatic, if the patient feels fluttering in their chest, they hit a button on the device and it tags that timestamp so that when people evaluate it later on, they can see, oh, you flagged it here and you had 7 beats of VTach. And it's a way for you to see what's going on. Oh, you flagged it here, you had, you were in AFib for 5 minutes. That's why you were feeling that, and then you went out of it. That's what you're trying to catch the rhythm, see how often it's happening. TTE, the transthoracic echo, or TEE. The transthoracic echo is basically your normal echo. The TEE goes through the esophagus and looks at the heart from behind it. What are we looking for with a TEE? Especially in a patient with AFib. We're looking for clots. And where are the clots mainly going to be? Where? Atrial appendage. They hang out there. So doing a TEE, transesophageal echo, will let us know, are there any clots already? If there's no clots, then there's no risk of what? Stroke. So I can cardiovert them, get them back into a normal rhythm, and not worry about a stroke. If I see clots on the echo, am I still going to cardiovert them? No. What's my next step going to be? Anticoagulate them. Then you can do it later on. So echo again. So TTE is your transthoracic, valve disease, chamber sizes, ventricular function, ventricular thrombi. It's good at seeing that. Looking at pulmonary hypertension and any type of pericardial disease. But your TEE, left atrial thrombus, mainly in that appendage. Also, again, to guide cardioversion. We don't want them to be in that irregular rhythm. We want them out of it. But if they have clots, the risk of a stroke, if I break them out of it, goes up. So we don't do it. So we have to anticoagulate them. So in the acute setting, they show up to the hospital. If they're stable, get the heart rate control. Medicine for that, we'll go through that in a second. If they're unstable, they're symptomatic, they're lightheaded, they're dizzy, their heart is flipping around in their chest, flip-flopping, then you would probably want to do a cardioversion. You give them some medicine to put them in a twilight, knock them out for 10 seconds, shock them, they'll go into a normal rhythm, and they wake up. Drug of choice for the acute setting is diltiazem, okay, the calcium channel blocker. Drug of choice for acute atrial fibrillation. You can also use beta blockers, digoxin, and amiodarone. Be very careful with amiodarone. Has Dr. Wood gone over amio yet with you? No. Not yet? Okay, one of the big things it can affect your liver and your thyroid. So before you start anyone on amiodarone, you got to check your baseline levels before you start amiodarone to make sure the liver's okay and the thyroid's okay, because it can be toxic to those organs. So we want to make sure that they're okay before we start that. It can also cardiovert them with amiodarone as well. So if you suspect that they might have a clot, don't use amio because it could cardiovert them to normal sinus rhythm. Then with a normal contraction, those clots can come out free. While it's AFib, they're not moving, the blood's just going to sit there. Caution with pre-excitation syndrome. If they already have underlying WPW and you put them in atrial fibrillation, remember, if you block the AV node, that accessory pathway becomes more active. Digoxin, beta blockers will block the AV node a little bit, suppress the AV node function, making the accessory pathway more likelihood to be stimulated. You got to watch hemodynamics. Because we know that they're not going to be filling very much, we got to watch out for blood pressure, perfusion, make sure it's still okay. The goal, get their heart rate controlled, but leave them in AFib. That's why you got to be careful with the amiodarone, because it may convert them. So oral cardizem, beta blocker, or some sort of combination. Long-term control, beta blockers show the best efficacy for rate control for AFib. So what are some examples of beta blockers? Metoprolol, labetalol, which is a different one, but yep, carvedilol, all the olols are the beta blockers. Digoxin is a last option, and only if the patient also has heart failure. Okay. There's an increased risk of death giving them digoxin, slow onset compared to the other drugs. The beta blockers have a faster action, and the other therapies are just as effective, so kind of just really like avoid the digoxin as much as possible for these AFib patients. The key is get them hemodynamically stable. Heart rate between 60 and 100 and blood pressure in normal ranges. That's the goal in the beginning with these patients. Now, what are we worried about with chronic AFib? So do we want to leave them in AFib, or do we want to convert them to normal sinus rhythm? So things to look at, how are they feeling when they're in AFib? Do they feel like garbage when they go in and out, or they don't notice it at all? If they feel like garbage when they're in AFib, then we may want to consider converting them to normal sinus rhythm or ablating that rhythm if we could. Anticoagulation, do we want to anticoagulate these people? And then the last one is left atrial appendage ablation beneficial. So when we have our atria, this is like the left atrial appendage. And clots, can form in this area. One of the treatments they're considering is ablation, where basically you ablate this and it fuses that off, kind of seal it off, so blood can't get into the appendage anymore. The other treatment is called a Watchman device. And basically the Watchman just sits over the left atrial appendage and closes it off. So it plugs the hole for the appendage so blood can't get into the appendage, because when blood gets in there, it just sits there in pools, and that's where the clots form. Yes?
Is AFib with like a controlled rate? Is it the atria like still firing? It's just not getting through the venas?
Yep. So Watchman device or ablation of the appendage to seal it off so blood doesn't get stuck there. So if the patient has been in AFib for less than 48 hours, you can assume no clot in the atrium. It's not enough time for a clot to form in the atrium. It's their first time having AFib. It's been less than 48 hours. Very, very, very low likelihood that they had a clot formation within the last 48 hours. So we can convert them to normal sinus rhythm, and no anticoagulation is required. If they are left in AFib, must anticoagulate. So if they're in AFib, you have to anticoagulate them. If the AFib has been greater than 48 hours, now you have to assume that there is a clot. So there's two things we can do now. If we assume they have a clot, it's been greater than 48 hours, that they've been in atrial fibrillation, we can order a TEE to visually confirm that there are no clots in the atrial appendage. Then we can cardiovert them. Or just start anticoagulation now. 3 months later, get a TEE, see what's going on. If they're still in AFib and the TEE is negative, then you cardiovert them then. So just see what's going on with the atrial appendage. You have to visualize it, make sure there's no clots. So 48 hours is the key. Less than 48 hours, assume no clot. But greater than 48 hours of persistent AFib, they've been in it for 3 days now, 4 days. At that point, consider they have a clot, get a TEE first, see what's doing. If you don't have access to a TEE, anticoagulate for 3 months and reevaluate then. Now, this is very important. This you have to know. Have you gone on this before? No. Okay, so this is the CHADS-2 VAS score, CHAD-2 VAS score. Each letter corresponds to a different parameter for your patient. So the first one, CHF history. If they have a history of CHF, they get 1 point on the score. H, hypertension. If they're BP, if they have hypertension, they get another point. Age, if age is greater than or equal to 75, they get 2 points for being elderly. When you add up all these, it's giving you a score. The higher the score, the bigger the risk, the bigger the reason to anticoagulate them. All we're doing out now is figuring out a score is, do we need to give them aspirin or do they need warfarin? That's what we're figuring out. D, diabetes. If they have a history of diabetes, they get another point. S2, prior stroke, TIA, or a history of a thromboembolism. They get 2 points for that. Any history of previous clots, strokes. They have vascular disease, prior MI, peripheral artery disease, any type of vascular disease, they get a point. Age, again, if they're less than 74, over 65, they get 1. And then sex category, if they're a female, they get 1. So you add it all up, and you get a number with the CHADS-2 VAS score. So CHAD-2, so CHF, hypertension. Age is 2 points. That's why the 2's there. D for diabetes. S2 for stroke. They get 2 points for history of a stroke. And then your vascular. Vascular, age, sex. Those are all the points. And then you add them all up. So it's a clinical prediction for estimating the risk of stroke in a patient with atrial fibrillation. So CHADS2 VASC, stroke risk for AFib. That's the only thing it's used for. And again, if they require anticoagulation or antiplatelet therapy, what's the difference? And which one falls into what category? What about the clot? So what is an antiplatelet drug that we give? Aspirin. So remember, aspirin makes the platelets less sticky, so they won't aggregate to start the clotting cascade. The anticoagulation is the warfarin to prevent the clotting cascade that happens later. Remember all the factor X stuff and where the intrinsic and extrinsic pathway combine, all that stuff. Well, all those NOACs, Pradaxa, Xarelto, all hit that factor X, which is the combo where both pathways combine. But basically, all you're trying to figure out is they need aspirin or Coumadin or both. If they have a 0, they're very low risk. No therapy is needed. If they have a 1, moderate risk, evaluate the risks and benefits. Elderly person who has a history of falls, would it be a good idea to put that patient on warfarin? No, because they have risk of falls. Is the risk of them falling and hitting their head greater than the risk of getting a stroke if they weren't on the medicine? Then that's what you have your discussion with the patient's family, whatever, you have your whole decision, and you come to a plan. Like, I don't think you'll be too much of a risk for Coumadin due to history of falls. And make sure you write all that in your note, because they're going to want to know, why are you not anticoagulating a person with persistent AFib? But when you document, I'm not giving AFib I'm not giving warfarin due to the risk of falls is too great in this patient. You've justified why you're not giving the Coumadin, you're okay. If it's greater than 2, and you see 2 is not very hard to get, they definitely need the oral anticoagulants or warfarin. If you give them warfarin, the goal is 2 to 3. When is the goal for warfarin 2.5 to 3.5? Did you guys do that one yet? Okay, so if they have a mechanical valve, and it's usually mechanical aortic valve, you have to go to 2.5 to 3.5 on their INR. Otherwise, it's always 2 to 3 if they're on anticoagulation. If you're not on any anticoagulation, your INR should be around 1. That's like a normal, nothing happening. If they have any valvular heart disease and AFib, you have to give warfarin. So remember, if it's subvalvular, you can give the NOACs. If it's valvular stenosis or valvular disease causing the AFib, you can't give the NOACs. Only Coumadin is what you're allowed to give. Again, when you're over 2, you get warfarin, apixaban. Those are all different types of anticoagulations. If they have a 1, no antithrombotic therapy or oral anticoagulation or aspirin. And if they're 0, they don't need anything. So 0, 1, or 2. Just 2, they get everything. 1, patient provider discretion. And then 0, they don't need anything. So anticoagulation, we have these direct oral or novel oral. You see NOAC, it just means novel, which just means that they're new. It is a first-line therapy for atrial fibrillation. Is this going to do anything with rate control for these AFib patients? Nope, we're just preventing a stroke. We still need to medicate those patients for the rate control. A lot of big-time safety compared to warfarin. If warfarin had to come out today, I don't think it would ever get approved by the FDA because the side effects are so bad. But it's been around forever, and we haven't come up with anything better. So unfortunately, we got to keep with the warfarin. The problem with these NOAC, the DOAC, some of them don't have an antidote to reverse it. So if their INR is way too high, what do we give them if they're on Coumadin? Vitamin K, and it's going to bring it back. Some of the other ones, some do, some don't. So be careful with those. So here's your Eliquis, Pradaxa, Xarelto, X, 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 X. Again, factor X. That's why they're all targeting factor 10. That's why they have X in it. Warfarin, again, here's your prosthetic mechanical valve. You know, obviously that's a valvular issue, but again, the goal is 2 to 3 for atrial fibrillation, stroke reduction risk. Any questions about atrial fibrillation? The treatment basically does beta blockers, get the rate controlled, and anticoagulation. Those are the two biggest things for atrial fibrillation. Holiday heart syndrome, usually due to alcohol use-related rhythm disturbances. In healthy individuals, marijuana has also been caused to some similar effects. The most common rhythm disorder is atrial fibrillation with holiday heart, though, which usually converts within 24 hours. Once like the alcohol gets out of your system and flushes out, it goes away. The diagnosis should be considered people who have normal hearts, who have new onset AFib. But the heart is structurally normal. You do an echo, all the chambers are normal sizes, everything looks good. They just have this problem. Although the syndrome may recur, it's usually benign. Any specific antiarrhythmic therapy is not indicated, and even modest amounts of alcohol may trigger the event. So obviously, patient education, tell your patients stop drinking alcohol. You can put them right back into this problem. Atrial flutter. What's the big sign for atrial flutter on EKG? Sawtooth pattern, coarse, right? You have very, very sawtooth pattern there. Most common symptom is going to be palpitations with these patients. Flip-flopping in their chest, fluttering, something's going on, they feel weird. Other symptoms, fatigue, dyspnea, chest pain. If they stay in this prolonged, fast flutter, may lead to decompensation with heart function. What is, if the atrial rate is this, what is the ventricular rate usually with atrial flutter? This is a clue. If you're always confused between atrial flutter or like atrial attack or whatever, usually with a flutter, the rate is about 150, the ventricular rate. The atrial rate is 200 to 350. But if you look at atrial flutter, when you guys review all your EKGs and look at a flutter, the rate usually comes around 150. They may get some dyspnea on exertion, some breathing issues, some edema in the legs, again with this atrial flutter. Not as well tolerated as AFib, maybe due to that really fast ventricular response that occurs with minimal exertion. Rare in patients with a normal heart. So if the heart is structurally normal, they shouldn't really go into atrial flutter. And usually with flutter, they'll either convert back to normal sinus rhythm or they just devolve into atrial fibrillation. Hypertension, angina, CHF, and syncope are all things that can be caused by atrial flutter. So here's your A flutter, that sawtooth pattern. Look, what's the conduction pattern? If you want to get very descriptive, you would say atrial flutter with a 3-to-1 conduction. 3 P waves for every 1 QRS. Treatment similar to AFib, watch out for clots. And if it's refractory to your treatment, beta blockers, whatever, that are still going in A flutter, Then you can ablate them. Undergo the EP study, do the ablation, you can get rid of those heart rhythms. Okay, let's take a break. Come back at 1:35. Okay, so do a quick review here. We have a rhythm strip. With a rhythm strip, can I do anything with MIs? No. You cannot diagnose an MI off of a rhythm strip. You may see changes in ST elevation or depression. What is the criteria for an MI to be an MI? 2 contiguous leads. I only have 1. I can't make a determination. If I see ST changes, I'll order a 12 lead and see what's going on. So from this rhythm strip, what are some ways I can calculate heart rate off of that rhythm strip? You can do the boxes, the little boxes, right? Find one that's on the line right here. So 300, 150, 100, 75, 60, 50, 40, whatever. So that's one way to do heart rate. What's another way? How do you know what 6 seconds are? 1, 2, 3, 4, 5, 6. So like 1, 2, 3, 4, 5, 6. The big lines are the 1 second. Then you have, let me erase some of that. It seemed confusing now. Okay. This is 1 second, 2 seconds, 3 seconds, 4, 5, 6. So you see how this is a bigger line? That means it's 3 seconds. How many boxes make up 1 second? Little boxes. Or how many big boxes make up 1? 5, right? 1, 2, 3, 4, 5. So 1 tick mark is 1 second. Count up 6 of them. How many QRSs you see? Multiply by 10. Gives you your number. So that's how you can calculate heart rate, those two. Okay, SVTs, again, supraventricular tachycardia. It could just be sinus tach for any reason. Very common arrhythmia. Paroxysmal, so what comes and goes is the PSVT. Regular rhythm, everything's normal, we're just fast. Supraventricular tachycardia or even sinus tach. If it's too fast to interpret a rhythm, the heart rate is going zipping around. Vagal maneuvers, first line therapy, try and slow down that rhythm so that you can actually see everything on that EKG. Terminate certain SVTs that will conduct through the AV node. Who has worked a Disney run yet? I know we had one already. Have you had a race yet? Okay, you will be running or doing the med tent at the Disney races. Sometimes patients will come out of when they're running and they're coming back to the med tent after they finish, they're in a PSVT. Okay, we try and get them out of it by carotid body massage. What are some other ways you can break these rhythms? Everyone know? One's called the diving reflex. What's that one? Anyone know what the diving reflex is? Put your face in cold water, or your hands in like ice water. That will help break SVT that go through the AV node. So just different tricks you can do to help break these things. Get a 12-lead EKG. You can give adenosine, which will help break that rhythm. Adenosine is for fast. Atropine is for slow. Do not confuse those two. Atropine and adenosine, they have different functions. If their heart rate is going so fast, they're not responding to any type of treatment that you're giving, you can cardiovert these. There's no risk for coagulation because they're not in AFib. Everything is still moving, so there's no blood pooling in the atrial appendage. So vagal maneuvers, bearing down, facing cold water, carotid massage. Be careful with old people. Why? Syncope, compression. If you do it too much, they may pass out. Or if they've got a bruit, you never listen, you just start doing it, you break those things free, then you cause a stroke. Blowing into a folded straw, again, you're just trying to increase your intrathoracic pressure to blow, or intra-abdominal pressure. Coughing. Here's your adenosine. Again, this is your first line. That's your second line therapies for the adenosine. Be careful if they have any breathing problems with adenosine. Be careful if they have pre-excitation or WPW with adenosine. Watch out for symptoms, feeling of doom. The heart may stop is like what they will feel like, but it's not going to happen. Dosing, 6 milligram IV push, followed by a normal saline flush. So whenever you push something, you want to follow it with a flush to make sure all the medicine gets out of that IV and going into the body. You can go up from there for the dosing. So it's 6 to start, you can go to 12. So moving on to premature ventricular contractions. When do you start worrying about PVCs? What's the number over this number? 3. Okay. So we have to watch out for them. The runs of consecutives, so more than 3, we worry about. Like PVCs in a row. Some people will have tons of them. So if we get that Holter monitor and you get the strip for the whole day, you're going to see a bunch of PVCs throughout the entire thing. Look for multifocal PVCs. What does a multifocal PVC mean? 2 different foci that's causing these signals to start. If they start competing with each other, then you get, what's it called? When they start competing with 2 points competing with each other. You get the wavelength. If you have 2 different foci, they have 2 different morphologies. So if you go into a VTAC with different morphologies, torsades de points, twisting of the points. It's 2 points competing. And be careful if you have a PVC occurring during an MI. So if they're having a heart attack and they're throwing a lot of PVCs, be very worried about that too. This last one right here is called an R on T phenomenon. We learned this one, I didn't call it this, but if a PVC occurs so early that it falls during the repolarization, ventricular fibrillation can result. When an extra beat occurs at a random time at the perfect instant, it can cause all this stuff to happen. What kind of tachycardic rhythm is that? Well, the classification of it, we learned there was prolonged QT will do it, increased automaticity will do it, and the triggered ones. This is a triggered tachycardia because you're putting an R on top of a T, which is like an R is the ventricular depolarization, is occurring at a time when it shouldn't, will send you into these bad heart rhythms. So again, ventricular fibrillation, this is your triggered tachyrhythm. Depends on the clinical context when it comes to PVCs. If you're drinking coffee and you get PVCs afterwards, it's just through the coffee, stop the coffee. Is it any underlying cardiac disease that's causing you to have these PVCs? If you're a young person, you guys are in school, you may be drinking more coffee than normal, you may get palpitations, it's just, but your heart is still structurally normal. It's just from the stimulation. Treatment, reassurance for most people, the PVCs will be fine. They'll feel a really hard beat, and then after that, they have like a normal beat, or they may feel like they don't have a beat. It's just a weird feeling. You may want to give some beta blockers if they are having this PSVT all the time, the PVCs a lot, where they are getting symptomatic from it. And other treatment is just looking at what the underlying cardiac disease is and treating that. Here's our torsades de pointe. Polymorphic ventricular tachycardia. Again, twisting of this QRS complex around the baseline associated with a prolonged QT interval. So this is the pathophysiology, what causes these to happen. prolonged QT, maybe congenital or acquired. If you have a young person with torsades, they may have a congenital long QT syndrome. So usually young people should not get torsades. Usually will terminate spontaneously, but can reoccur as well. And if it does reoccur enough, it can devolve into ventricular fibrillation. This is still a tachycardic rhythm. Hasn't gone into real fib yet. So here's your torsades. Very easy to localize. Again, they don't all look the same. This group is different from that group. Just different areas. Treatment, magnesium is the top one. IV mag for torsades. Treat the source, stop any type 1 or 3 antiarrhythmics, antibiotics, antifungals, any underlying medicine that they're on. Be careful, but IV mag is the one. If they're unstable, then you defib. You can't use cardioversion because of the polymorphic nature. You're not going to get all of them out. So you have to give them the stronger dose, the bigger joules, the bigger energy. The defibrillator is the stronger dose. Cardioversion is very, very low. Or you can do also the EP study to see what's going on. Where are these impulses coming from? Where are these foci? And if you can localize where these foci are on the heart, you can ablate those rhythms so they'll never go into torsades again. Again, EP studies can be curative. Here's our VFib, most commonly identified arrhythmia in cardiac arrest. Severe derangement of the heartbeat that usually ends in death within minutes because there's no blood leaving the heart. The heart is just fibrillating, the ventricles are fibrillating, they're not squeezing, no blood can leave, and they die pretty fast. So therefore, immediate access of a defibrillator is required. That's why we give them an internal one. So that if we know they have a history of sudden cardiac death or a history of it, or they're at risk, put it that way. If they're at high risk for sudden cardiac death, we give them a defibrillator. So they can be anywhere in the world. If they go into this rhythm, the device will defibrillate them and they'll wake up and they'll be okay. If they don't have the device in, then you're at their mercy for the nearest defibrillator. And you got to find it. So these patients, VFib, defib, just remember that one. Immediate defibrillation right away. Post-resuscitative care, if they do come out of it, use any antiarrhythmics that they were on. If they were working, put them back on it. Watch out for hemodynamics instability. Make sure their heart rate and their blood pressure are controlled. Check for any complications, aspiration pneumonia, CPR-related injuries, cracked ribs from CPR. Watch out for those things if they had CPR done. And, need for emergent interventions, thrombolytics, antidotes, decontamination, depending on what the underlying cause is for them to go into ventricular fibrillation. Here's VTAC. Sudden cardiac deaths are caused by VTAC or VFib. 300,000 deaths per year. Very fast ventricular rate and dissociated from an underlying atrial rate. You can't see the atrial rate in this strip, but the atrial rate will not be anywhere near as fast as the ventricular rate here. The atria are still doing everything normal. It's just the ventricles gone haywire, and they're doing all this. This is not an atrial problem. This is a ventricular issue that's causing this to happen. Treatment depends. If they have a pulse, if they're stable, just give them pharmacological therapy, amiodarone or procainamide. If they're unstable, blood pressure is plummeting, they can't support unstable synchronized cardioversion. So you cardiovert them, which is low joules. If they have pulseless VT, they're in VTAC and you do not feel a pulse, you have to defibrillate that person. They're not getting any blood out, nothing's perfusing their organs. You have to defibrillate that person to get a pulse back. And then again, post-resuscitative care, same as for VFib. Watch for any CPR issues, whatnot. Ashman's phenomenon is a weird one, and you may have got it in EKG, I think, right? You didn't do this one? Okay. It's an aberrant ventricular conduction, usually resembling right bundle branch block. Does this look like a bundle branch type pattern? Right? The bunny ears, okay? It resembles that. It's an aberrant beat, which means it's something that happened that shouldn't have been there. Following a short RR interval, preceding relatively prolonged RR interval. So here's our long, and there's the short. So you have what you think is like a sinus pause, but a beat comes in. Then you get this aberrancy. So if you see an aberrant rhythm like that, because if it was a right bundle branch block, that rhythm would be all across the board, right? It wouldn't change. But it only shows up one beat. So because it only shows up once, it's an aberrant beat. Just think of Ashman's phenomenon. Often seen in AFib, asymptomatic, and doesn't require any specific treatment. So again, if you see an aberrant beat, it looks like a right bundle branch block, has the bunny ears, but it's only one, and there's a weird interval around it. It's this Ashman's phenomenon. And this is what it looks like again. Usually going to be in V1 through V4, V3 is usually where you'll see these type of beats happening, which is why it's only up here. You don't see it on these leads, right? Okay, let's review fast right here. One, AVL is what? Lead 1 and AVL. Lateral and anterior a little bit too. 2, 3, and AVF. Inferior. V1 and V2. Septal. If you go V1 through 4, anterior, lateral. So make sure you get all those locations down. You know exactly what you're looking at. Okay? We don't care about AVR except when? Well, okay, Noel, if it's up, what does that mean? Okay, if you ever see AVR being positive, check your leads, because you may have reversed them. That's one of the main reasons. If you ever see AVR being positive, check your leads. You may have reversed them. They're all labeled, but that's one cause. Okay, so history. No issues on its own. Very, very mild symptoms. May have an irregular pulse when that aberrancy occurs, because remember we have a long R to R interval and then a short one that may feel like a fluttering, skipping around in the chest. Diagnosis, obviously, is going to be EKG. You'll see it on the 12 lead. Treatment, just any underlying rhythm abnormalities, but really no specific treatment for Ashman phenomenon. Moving on to AV blocks. First degree, just a long PR interval. So again, this case right here, what's the rate of this one, the top one? Okay. Is it normal, fast, or slow? Normal. So what would be your diagnosis for this one? Sinus rhythm with first degree AV block. It's still sinus rhythm. We're still following normal pathways. It's just we have a little bit of a block in the AV node. So it's sinus rhythm with first degree AV block. It could be sinus bradycardia with first degree AV block. Just so you know, letting you know on your your exam, you could have like, don't be confused where it says like sinus brady with this, like, is it really sinus brady? Just double check and make sure. Type 1, Winky Bach. Longer, longer, longer drop. Okay, the poem's here as well. Type 2, PR interval is fine, but we randomly drop a QRS. So we're good here, we're not good there. This is where the beat should be. We're good there, good, good. Do you guys understand what I meant, why the beat should be there? You just march it out. The P waves should be marched out. They're equal. The Q waves should go there. But again, the distance is equal going across. So we know the rate is normal, or sinus rhythm. The last one, or this is a high degree AV block, but third degree AV block, there is no communication at all from the top and bottom. Why in a complete heart block do we have a wide QRS? The ventricles are handling their own ventricular rate now. So it's going to be a wide pattern because the ventricle beat is originating in the ventricles. So it doesn't follow the normal pathway. That's why third degree AV block has a wide QRS compared to the other ones. So clinical features, the biggest thing are these pauses. They feel like they don't have a beat. Well, because they dropped the beat, that's why they don't have a beat. They lost it. First degree block doesn't require any treatment at all. Just leave it alone. Don't worry about it. Second degree AV block type 2 and third degree, they get pacemakers. Just give them a pacemaker. Permanent pacemaker, PPM. They get a permanent pacemaker. Their heart rhythm is not going to come back. The communication between top and bottom is not going to come back. Just give them a pacemaker. Second degree type 1 does not require a pacemaker unless they're very symptomatic with it. Then you can give them one. But second degree AV block type 1 does not require a pacemaker. AV block type 2 does. Here's type 1. So acute treatment of Mobitz type 1, so PR interval lengthen, 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 drop. Any patient who has symptoms or AMI, they have a history of acute myocardial infarction, ischemia, or the infarction, get them admitted with telemetry monitoring and transcutaneous pacing. We put wires on top of you that can handle the pacemaking of your heart. They're not permanent. We're not inside the body. It's outside. If we need to support your heart rate, we can do that. If they're symptomatic, you can do atropine or transcutaneous pacing. Be very careful if they have any underlying CAD. So if they have CAD, don't give atropine pretty much. You can cause some ventricular arrhythmias to occur, so you're making the problems worse. So type 1 is more management of the patient. So if you're going to study type 2, second degree type 1, because we know type 2 and 3 just get pacemakers anyway. Type 1 you don't worry about. All you got to worry about treatment is this one. So again, PR interval lengthen, then we drop it, then we get longer and longer, and then we drop. Okay. Type 2, telemetry monitoring. They may need some transcutaneous pads. Again, this is just on the admission to the ER as soon as they come in. They'll be on a telemetry floor, cardiac floor, so they're monitoring all the time. Urgent cardiology consultation, they need to be involved to make sure the heart rhythm's okay, and then they'll manage all that for you. May require a pacemaker, and then obviously the more severe they are, hemodynamically compromised, they get a pacemaker anyway. So you can try and treat them a little bit, but if they have type 2, most likely they'll need a pacemaker. So here's type 2, the PR interval is fixed, and then we just have drop, drop, PR interval is okay, it's okay, it's okay, drop. So it's a random dropping of these QRSs, which is the problem. Eventually, it may not sync up again, and now you're in third degree AV block, and there's no more communication from top to bottom. So that's what's going on with Mobitz 2, second degree. Third degree, dual chamber pacemaker. They got to sync up the top and the bottom. Treatment in emergency situation is electrical pacing. But now they're saying American Heart Association, they can try to give some atropine to see if it helps. Atropine is effective for early heart blocks, first degree, second degree type 1. But after that, you stop. You don't give any more atropine for type 2 or third degree. So here's your third degree AV block again. What's the ventricular rhythm on this one? You have a 6-second strip. Yeah, makes sense, right? Ventricular rate normally is 20 to 40. We're at 30. Ventricles are taking over. What's the atrial rate? 60. That's normal. So the atrium are working normally, keeping the heart rate the way it's supposed to be. The problem is there's no more communication because the AV node is blocked now. There's no more communication. So the atria are going to be at their normal intrinsic rhythm, around 60 to 80, whatever it is. Ventricles, because nothing is telling it what to do, they go at their own rate of 20 to 40. Okay? So this is the same poem I gave you guys. Antiarrhythmics. This is now going to the drugs. Antiarrhythmics are classified by where they work on the action potential. So now you know why I was so hard on you guys. Make sure you know what was going on in each phase of those action potentials, because the drugs that we give affect certain phases of what's going on. They can also cause arrhythmias, so you have to be careful when you give these drugs. Some of them may prolong the QT interval, and if they do that, then they're at risk for getting torsades. So be very careful. Classes, there's only 4. Some of them do have some sub ones. But class 1, they block the sodium channels. What phase of the action potential is this going to alter? Depolarization, right? Now we're going to alter our depolarization. What's that going to do to our heart rate? Decrease it, bring it down, get it more controlled. We have a couple of different classes. 1A may cause QT prolongation. 2, no effect on any conduction or any refractories. 1C may prolong the QRS complex, so it may widen it a bit on the QRS. Class 2 antiarrhythmics are your beta blockers. So class 2, block the beta receptors. What's that going to do to your heart rate? What's it going to do to the contractility? Okay, very good. Class 3 blocks the potassium channels. What's that going to mess up? Repolarization. Look at what it's doing. Prolongs the QT interval when you give a class 3, which blocks the potassium. Class 4, or your calcium channel blockers. What phase is this going to alter? The plateau phase. What segment on the EKG basically resembles the plateau phase? The ST segment is the plateau phase, because then what comes after the plateau phase? Repolarization. And ventricular repolarization on the EKG is the T wave. So the ST segment is the plateau phase. So the calcium channel blockers will affect the contractility of the heart as well. And the last one are these nodal blockades, class 5, and it's your adenosine and your digoxin. So specific 1A drugs is quinidine, procainamide, and disopyramide. Clinical uses for quinidine, PACs, those abnormal heartbeats, extra beats thrown in there, preventing SVT, watching out for WPW. Toxicities with quinidine will give GI problems, may cause some vasodilation. synchronism, which is a flushed diaphoresis, tinnitus, confusion. It's a whole cascade of symptoms. Can prolong the QT interval, and because of that, just remember, if you prolong the QT interval, torsades. It's one of those types of tachycardic ways to cause it. Procainamide. We mentioned procainamide a little bit before, talking about AFib. Again, uses for any supraventricular tachycardia, AFib. Reentry tachycardia is good for that. And for ventricular rhythms, VTAC and WPW as well. So these are the uses for procainamide. Toxicities can cause a lupus-like syndrome, and there's our QT prolongation again. Okay. Special considerations for procainamide. Continue until the rhythm is suppressed, meaning the rhythm doesn't come back anymore. QT is prolonged greater than 50%. So you have to get a baseline EKG to see what their baseline QT interval is. If it's 400, it's got to go up to 600. When it gets over 600, that's 50% or greater, then you stop the procainamide. Or they're already on max dose. You can't go any higher. Just switch off to something else. So these are some special considerations for procainamide, mainly AFib. Class 1B inhibits the fast sodium channel. These are lidocaine is a big one, tokenide, mexilidine, and other examples of that. So lidocaine. What do we give lidocaine mainly for? Numbing, right? But it's got some other causes as well, other indications. Recurrent VTAC is what lidocaine is good for. IV only followed by a bolus. So we can only give lidocaine in the hospital. It's not a drug you go home on. There used to be a lidocaine prophylaxis in patients who had an acute myocardial infarction, but we don't really do that anymore. Side effects, mainly some CNS issues, confusion, dizziness, seizures, and they're all dose related. So the higher the dose, the more likely it is to get these symptoms. Reduce the dose and they go away. So lidocaine, recurrent ventricular tachyarrhythmias, that's the indication. What are some side effects of it? Tokenide is an analog of lidocaine, may be given orally, whereas lidocaine was only IV. This they can go home on. Toxic CNS effects are common and limited use with it. We don't really give tokenamide very much. Mexilidine, similar to lidocaine, a lot of CNS issues with these drugs. No blood toxicity, meaning it just goes in your dose dependent. It goes up. It's not going to cause any issues the higher it goes. Diphenylhydantoin. Dantoin is also found in anti-seizure medications. Okay, but it's an anti-seizure med that has some 1B properties, so we give it here as well. Usually only due to digitalis-induced arrhythmias. The last thing we're going to discuss today is digoxin, but when you have digoxin toxicity where it builds up in your system too much, we give this one as like the antidote for it. It could be IV or oral. Again, your CNS side effects, some GI with this one. 1C are rarely used. These are the most potent sodium channel blockers. They prolong the refractory period within the AV node and accessory bypass tracts. What is that going to do if you increase the refractory period? Is it going to inhibit or stimulate this? It's going to inhibit. Okay? Very high mortality rate with their use. We don't really use them. This is flecainide and propafenone. Flecainide has been used a little bit, but you have to really do a whole lot of monitoring with this. A lot of BMPs to make sure the sodium levels are okay and stuff like that. Class 2 antiarrhythmics are your beta blockers. Obviously, therefore, arrhythmias going too fast. Work by inhibiting sympathetic activity. They may cause some PR prolongation because they do suppress the AV node a little bit, but not going to be any issue with that. It's just part of the drug. Used in suppressing tachyarrhythmias induced by excessive catecholamines. Used to slow ventricular rate in AFib, A-flutters. Again, these beta blockers are very good for rate control. May terminate re-entry heart rhythms, suppress PVCs, and does not prolong the QT interval. So beta blockers are very safe for fast heart rates. Class 3 antiarrhythmics. They prolong the action potential and refractories of Purkinje and our ventricular muscle fibers. So these are mainly going to be affecting our ventricles, and they're also going to prolong the QT interval as well. Amiodarone is the big one. Sotalol is another one that's used a lot. This is also known as beta pace. Beta pace, sotalol, you have to start while they're in the hospital. Because of the increased prolonged QT interval, when we give you sotalol, we want to check over the weekend to see how your EKG is doing. As long as it's okay, we send you home. Let's go over amiodarone. Shares actions with each of the other classes. It's going to decrease sinus node firing rate. What's that going to do to the heart rate? Decrease it, so suppresses automaticity. Interrupts any re-entry circuits, so it stops those. It will prolong the PR, QRS, and QT intervals on the EKG. So again, get a baseline EKG is so important before you start a lot of these or any of these antiarrhythmics. See what's going on with that QT interval beforehand. It's a negative inotrope, and it's also a vasodilator. So indications for amio, SVT, AVNRT, your reentry ones. AFib is the big one, and your SVT with a bypass track, like your WPW. It's another way of getting through. And it's also very good with ventricular tachycardias and fibrillation as well. So amiodarone is also used to treat those type of arrhythmias as well. Long half-life, 25 to 60 days. It sticks around for a long time. Some toxicities they can cause. Pulmonary toxicity with a 10% mortality rate just due to amiodarone affecting your lungs. Cardiac, it can cause torsades de pointe. Here's your liver. There's your thyroid I told you about before. Check before you start them on this. LFTs, thyroid panel, see what's going on. One of the interesting side effects of amiodarone is a blue-gray tint to their skin. Hyperpigmentation, blue-gray, due to the amiodarone. Very rare, though. Due to the toxicity, again, you have to monitor them before you start. Even doing pulmonary function tests, just to make sure the lungs are okay, since we know that amio can be toxic to the lungs. Interacts with many drugs, including warfarin and digoxin. So be very careful whenever you start amiodarone. Make sure they're not on any other drugs that can mix together. Make sure the liver's okay, thyroid, the lungs are okay before you start this drug. Class 4 are your calcium channel blockers. Verapamil, diltiazem are the big ones that we'll use. Primarily sinus arrhythmias and sinus and AV nodes. Decrease heart rate, decrease conduction through the AV node. Helps with re-entry rhythms. And the primary use is re-entry PSVT. So it slows the rate for these atrial arrhythmias. This is what calcium channel blockers are for. Diltiazem or verapamil. Verapamil, second drug of choice for SVT. Diltiazem is very good for rate control for AF and A-flutter. So you can give diltiazem for AFib. You can give verapamil for SVT. Some toxicities may enhance some AV node delays because it does act on the AV node to slow conduction through it. So it may cause some PR interval delays like type second degree AV block or first degree AV block. I'm sorry. Maybe a bradycardia from reducing the heart rate. Don't use calcium channel blockers in wide complex techies with unknown origin. Don't do it with AFib with WPW. Don't give calcium channel blockers if they have sixth sinus syndrome. And don't give them calcium channel blockers if they already have an AV block and they're not supported by a pacemaker. So let's say you had to give calcium channel blockers to a patient for some reason, but they have this problem, but because the medicine is requiring their heart rate to go lower than they're comfortable, you give them a pacemaker, and now you can give them all the drugs you want. It doesn't matter because the heart rate's not going to drop below 60 or whatever number you pick. So the pacemaker going in is more like a support, and now you can give medicine like crazy because beta blockers all you want. The heart rate's never going to drop below 60. So there's ways to give pacemaker to treat and help. Class 5, adenosine is the first one. Very short half-life. That's why we give it for certain things real fast as far as in an emergency treatment because we don't only last for a couple of seconds. Most effective drug for rapid termination of paroxysmal supraventricular tachycardia. So adenosine is very good. So again, if there's coming in, you're seeing a patient in the emergency room, their heart rate is 200. You got to break this SVT. Adenosine is a great one to do that. Suppresses spontaneous depolarization of the SA node and slows the conduction through the AV nodes. So it kind of calms things down to allow it goes back to a normal rhythm. Some effects are very transient. They may get a headache, chest pain, some bronchoconstriction as well. Need higher doses if patients are on theophylline or caffeine. So if you ask your patient what drugs are they taking, theophylline is mainly used for for lung issues, and caffeine obviously for coffee. Digoxin is the last one. It's also a class 5. So class 5 is adenosine and digoxin. Slows ventricular response in AFib, and it's a third choice for PSVT. So it's very good for slowing things down if they're in heart failure. It's really good for heart failure. But it does have some side effects. Digoxin it can cause some nasty stuff. Some dizziness, confusion. The GI complaints are the big ones. If they have digoxin toxicity, meaning the digoxin built up in their system too much, they can get some nausea, vomiting, diarrhea, and stuff like that, abdominal issues. Some visual problems, and it may actually induce an arrhythmia as well. So if your patient has renal failure, be careful with digoxin because, again, it's metabolized through the renal system. If your kidneys aren't working well, you're not going to be able to metabolize the digoxin. It's going to build up in the system and cause toxicity. This is important, especially for your exam on Wednesday. If you see a scooped ST segment like that, that's the ladle sign. That's caused from digoxin toxicity. You will see that in all the leads across the board. So if you see a ladle sign, that is due to digoxin. You seriously just watch, just go through rhythm strips and EKGs and just answer questions. That's the best thing you can do. And obviously know all your normal values. You know, what little boxes, what time is in that, a big box, add them all up, know all your intervals. And you guys will do your review with Ovalle in the morning. So good luck.